Hi, everyone. My name is Dr. Ashley Clark. I am an associate professor and division chief of oral pathology here at the University of Kentucky. And tonight I'm going to talk about routine cancer screening and what to look for in your patients. So conflicts of interest and disclaimers. This presentation is being sponsored by Perel Pharma, and they offered to cover my honorarium for this talk. The opinions expressed are mine, not those of my employer, and the opinions should not be construed as advice for specific patients. However, I will put my email address at the end, so if you do need advice for specific patients, I am happy to help you. So objectives: upon completion of the course, the participant should be able to discuss potentially malignant disorders, specifically leukoplakia. That's what we'll focus on. Recognize leukoplakia and how it may progress, determine an appropriate treatment plan, and discuss how to help prevent squamous cell carcinoma in your patient population. For those of you who don't know me, number one, you have probably realized by now that I talk very quickly. So there is no harm in putting in the Q&A or the chat if it's able to tell me to slow down. I will not take offense to that. But I have a lot of content to get through and I like to keep it fast-paced. I usually like to show a picture of my family just because I do these at home quite a bit, and I've got these little guys running around, this big guy chasing them. So this is my son Cash, and this is Zach, and this is my husband Damien. But I'm at work, so there should be no interruptions tonight. And this picture is quite old because now all of our current pictures, you can't really see any of us. So, okay, so as an introduction, about 54,000 people in the US are diagnosed with oral and oropharyngeal cancer every year, and about 11,000 patients die. So these statistics, I wish they would tease out oral versus oropharyngeal, because those are two different types of squamous cell carcinoma to my mind. Number one, the oral cancers are the traditional cancers caused by smoking and drinking, and that's what we'll focus on in this talk. The oropharyngeal cancers are primarily driven by high-risk HPV and occur independently of tobacco status or alcohol use. Men are twice as likely as women to be diagnosed with oral cancer, and 62 is the average age of all patients. But again, I will say the oral cavity proper, those patients tend to skew a bit older. The oropharyngeal cancer patients are usually white men between the ages of 40 and 59. So those skew a bit younger. And when I say oral cancer, I mean squamous cell carcinoma. I should probably make that clear because squamous cell carcinoma is by far the most common type of oral cancer. There are other types of oral cancer like salivary gland malignancies and et cetera. But for this lecture, if I say oral cancer, I mean squamous cell carcinoma. I like to put this slide in here because I want the audience to know there is a rising incidence of squamous cell carcinoma affecting the tongue in young white women. I just last week diagnosed a 26-year-old female with an invasive ventral tongue cancer. So there's been a 0.6% annual increase every single year from 1973 to 2012. And we don't know why it's happening. Tobacco and alcohol are not etiologic factors. So even if these women did smoke, it would be an insufficient amount to account for cancer development. And these are all HPV negative, so they're not driven by high-risk papillomavirus. And all that to say is I've seen far too many of these tongue cancers in young women. The oral healthcare provider doesn't have a high degree of suspicion because they're, women my age who don't smoke and maybe don't drink and they don't have HPV. So I just want you to keep an eye out for that. If something looks funny on a woman's tongue, go ahead and get it biopsied, even if she's a younger woman. As I alluded to before, there are two distinct types of oral and oropharyngeal squamous cell carcinoma. So the HPV positive and HPV negative, and they each warrant their own discussion. They each have different etiologic factors, occur in different locations, affect different demographics. And actually, I didn't mention before, but they have different survival rates. So there is an improved chance of survival with HPV-driven cancers by about 69%. So the 5-year survival for HPV-negative squamous cell carcinoma hovers around 45 to 50%, but the 5-year survival for HPV-positive squamous cell carcinoma is around 80%, even though 80% of them have metastasized at the time of diagnosis because they're very sensitive to radio and chemotherapy. So this talk, we'll focus on HPV negative squamous cell carcinoma. And the reason I want to do that is because I'm talking mostly about oral cancer screening here. So let's catch these lesions before they turn into cancer if we can. And for those HPV positive squamous cell carcinomas, there's no known dysplastic phase. So it's not like the traditional, smoking and drinking associated cancers of the tongue, where we'll see a lesion and it progresses. That doesn't happen, as far as we know, for HPV positive squamous cell carcinoma of the oral pharynx. So what causes HPV negative oral squamous cell carcinoma? So primarily it's tobacco. I mean, nearly everybody who gets oral cancer that I diagnose, they come with a long history of tobacco use and alcohol use. And then of course, for the lower lip vermilion, sunlight. There are a few systemic conditions or states that can drive oral squamous cell carcinoma. Probably the most well-known example is iron deficiency anemia. And then there are some rare heritable conditions that can cause squamous cell carcinoma or increase the risk. But I like to tell my patients, especially ones who have parents or relatives with oral cancer, heredity does not appear to play a major causative role in squamous cell carcinoma. So let's roll right into potentially malignant diseases, and the terminology changed, by the way. So we used to call these pre-cancers, and then the WHO changed the terminology. So now these are called potentially malignant diseases, but we'll focus on leukoplakia. So first, we have to look for it. So clinicians should perform a conventional visual and tactile examination, both intra and extraorally, on every patient every time. So I've put the pattern that I use to ensure I look everywhere. So that just means it's so routine by now that I know I've hit everywhere. And this is on your handout, so I'm not going to read it to you, but you want to palpate these areas too to check for submucosal tumors if you can, if applicable. Oral dysplasia is present in up to 1 in 200 patients. That's probably a little bit high, but that definitely means that all of you could have a patient with dysplasia right now in your practice. The most common way dysplasia presents is leukoplakia. Leukoplakia affects 2.5% of Americans. Now, most leukoplakia is benign hyperkeratosis, but about 20% of leukoplakia will reveal dysplasia or worse, like cancer on biopsy. And I put a picture here courtesy of Dr. Pepper, and these are white lesions that are crawling around the crevicular or around the edge of the teeth, and I'm worried about it involving the crevicular epithelium. So even though this lesion looks fairly innocuous, it's kind of thin and it's small, this is a highly worrisome lesion for me, and we'll talk more about that in a second. So I just want to clear up, when I say leukoplakia, I mean a white plaque, and I don't know why it's there. So some people say leukoplakia when they mean a white patch, but I reserve it for a white patch where I don't know what it is. So for example, tobacco pouch keratosis, even though that might present as a white lesion, I don't call that leukoplakia because I know why it's there. It is a clinical term. If you do biopsies, you will never get leukoplakia back as a diagnosis. And true leukoplakia should always be considered a potentially malignant disease. So for example, if a patient has true leukoplakia, but it comes back as hyperkeratosis, that patient still needs follow-up because it's a potentially malignant disorder. So this is tobacco pouch keratosis. I wouldn't call this leukoplakia, even though it's white. And here is this, I like to put my sources at the bottom of each slide. This one I must have forgotten. This is from Dr. Jerry Boko. But this is a white patch, but I can see that it's being caused by chewing. It's a frictional keratosis. And something I want to call out is you can see how this white sort of fades as you go off the ridge. So there's not a really nice, well-demarcated line of leukoplakia. You can't really tell exactly where the white ends in the alveolar ridge, the normal mucosa, begins. So this is a really good sign for me that we're not dealing with a true leukoplakia, that this is frictional keratosis. Now, once we get off of the occlusal table, then I do start worrying about leukoplakia, and I'll show you an example of that in a minute. So who gets leukoplakia? So mostly older patients. So around 10% of men over the age of 70 will have some form of leukoplakia in the oral cavity. And the leukoplakias with dysplasia, sort of the danger zones, are the lateral ventral tongue or floor of mouth. And I think you all know that. So the earliest way leukoplakia presents is with thin leukoplakia. So this is slightly elevated gray or white plaques, and these will have sharply demarcated borders, unlike those frictional keratosis borders. The lesions might look wrinkled, they might appear fissured, and when you biopsy these, because you must biopsy them, they hardly ever show dysplasia, and the malignant potential hovers around 4%. But there is an exception. Sometimes thin leukoplakia can be co-infected with a high-risk strain of HPV. And in that case, the lesion presents as a carcinoma in situ. So there's just no way to tell by looking. So for example, this is thin leukoplakia, and this turned out to be hyperkeratosis. So this is fairly innocuous looking to my eye. It's definitely a leukoplakia. It's a white patch. I don't know why it's there. It's fissured and it's slightly raised, very well demarcated. So that's not a great sign that it's trauma. Usually with trauma, it's not so sharply demarcated, but this was just hyperkeratosis. Here's one where I was showing you with the frictional keratosis, it's sort of limited to the occlusal table. Once it starts, sort of growing off onto the gingiva, that's when it becomes true leukoplakia. So this is a thin, sort of fissured or wrinkled leukoplakia, sharply demarcated border again, and this was hyperkeratosis. We have another lesion of leukoplakia, very thin leukoplakia, and this was discovered by one of our dental students here at the University of Kentucky, who took this excellent picture for me. So very sharply demarcated borders. This was just hyperkeratosis. However, it needs follow-up because there's no reason that should be there. So this should be considered a potentially malignant disorder. So I'll tell you how I follow these when we come to treatment. So another example of thin leukoplakia, these very sharply demarcated borders where you can tell exactly where the leukoplakia ends and the normal skin begins. And this one was mild dysplasia. And finally, again, a very thin leukoplakia, sharply demarcated borders, but this patient actually had carcinoma in situ. It was co-infected, or it was infected rather, by a high-risk HPV, and this patient, unfortunately, has had numerous surgeries to try to get rid of this carcinoma in situ. So that was thin leukoplakia, the earliest way in which leukoplakia presents. Thin leukoplakia can progress. It can become thicker. It can become more distinctly white and more distinctly fissured. And then I call that thick leukoplakia. And the good news is most leukoplakias stay at this stage and some even regress. For example, if you have a patient who smokes and they stop smoking, their leukoplakia might go away. So here's an example of a thicker leukoplakia. Again, those sharply demarcated borders, very fissured, and this showed mild dysplasia on biopsy. This is in a high risk location here. So this is even more pronounced, this thick leukoplakia. But even with this very sort of alarming appearance, this was only mild dysplasia with hyperkeratosis. And we'll learn the lesions of leukoplakia start off thin, and then they get thicker, and then they thin out. So the this stage isn't as bad as when they start to thin out and show areas of red. And I'll show you some pictures of that. So some lesions of thick leukoplakia do progress and they develop increased surface irregularities, and that's called granular or nodular leukoplakia. If they have wart-like projections, it's termed verruciform leukoplakia. You might hear that term. So that's what this is looking like. So we have this sort of rough appearance to the leukoplakia. It's more raised than the other examples I've shown you. But if you look here, this is an area in which the cells are dividing so rapidly that they no longer are doing what they're supposed to do. So epithelial cells are supposed to produce keratin. Keratin is white. Well, this is dividing so rapidly, it can no longer produce keratin. So this is actually the worst part of the lesion. That's the severe dysplasia, even though this is more striking to the eye. And I just received this photo yesterday from Dr. Guyette. So this was what I call an atypical epithelial proliferation. So to my eyes, this is almost certainly a cancer, and this all needs to come out. These gingival carcinomas are very, very tricky because there's crevicular epithelium in here that may or may not be affected. And it's really hard for me to, when I biopsy these, because I do my own biopsies, it's really hard for me to get a nice piece of it with that. And because I'm not trying to compromise aesthetics and et cetera, but this is no good. And then here's another verruciform leukoplakia. This was verrucous carcinoma. Like I mentioned, so if the lesion then progresses, it starts to show scattered red patches. That's called erythroplakia. Or the whole lesion can be called erythroleukoplakia. Once the lesion has red areas, it's usually advanced dysplasia when we biopsy it. So I consider lesions of erythroleukoplakia severe dysplasia until proven otherwise. So this one was a moderate dysplasia. So you've got this sharply demarcated white lesion and it's starting to thin out here. Here's an erythroleukoplakia and this is severe dysplasia. And to my eye, this is not as easy to see as those striking leukoplakias that I showed you earlier, but the dysplasia is much worse. So here's another example of that. So this was severe dysplasia, and this is catching my eye, but this is actually a worse spot, right? Or in here, because that's where the erythroplakia is, and red is worse than white when it comes to oral path. I do want to take a few seconds to talk about proliferative verrucous leukoplakia. So this is a high risk form of leukoplakia. I say it's rare, but I've been seeing it more and more and more lately. So I think it warrants mentioning. So it's characterized by multiple hyperkeratotic plaques with roughened surface projections. And what happens is these lesions start on the gingiva and then they slowly but surely spread throughout the mouth. We can cut them out, we can laser them off, but they're going to come right back and continue to spread. And if untreated, these lesions almost always turn into cancer. It takes about 8 years for them to turn into cancer. So PVL is difficult to treat because, like I said, if you cut them out, if you laser them, they come back. They have almost 100% recurrence rate. It's unusual because there is a 4-to-1 female to male predilection, and we don't know what's causing PVL. It's not associated with tobacco use. So it's really hard to explain to these patients, like, I don't know why this is happening to you. Also, the only treatment I have is to constantly burn your tissue, and then it's going to come right back. So it's a really frustrating diagnosis, but it's an important one to not miss. So here you have this leukoplakia. It's fissured, it's slightly raised, but if you look up here, they've got it up here as well. So this is where it starts to scare me a little bit because I don't know what it's doing when it comes to the crevicular epithelium. I don't know if it's crawling down the tooth root via the crevicular epithelium and turning into a malignancy down there. Here's a patient that was sent to me. So they were sent to me for this lesion, and I take pictures of all my patients. And when I took the photos, I noticed this area down here. Now, I highly doubt this area was present when the clinician referred this patient to me. I believe this to be a new area of leukoplakia. It's really faint and subtle. But then I looked on this side and I saw these, sort of hyperkeratotic plaques. And then the reason why this patient was sent to me was this big lesion here. It's sort of hard to get a nice picture back there. I apologize. So this was just hyperkeratosis, but I did diagnose her with proliferative verrucous leukoplakia. So it's early PVL. We've caught it early. And I put her on 3 months reevaluation. I take pictures at every 3 months. And here's what it looked like 6 months later. So just sort of compare side by side, like that's how rapidly her tissue was growing. And the rule is you're meant to rebiopsy it if the lesion changes at all, because that means there's a new diagnosis. This was still hyperkeratosis. There was no dysplasia in it, but I went to have this tissue removed because there's a fairly long waiting list. So even in Houston, that's where I was when I saw this patient. I used to work at University of Texas at Houston. And by the time she got there, I was worried it would be growing even more. Here's another patient I had while I was working at University of Texas at Houston. This patient was diagnosed with lichen planus, and I'm going to tell you why that probably wasn't a bad diagnosis. So under the microscope, lesions of PVL and lesions of plaque-like lichen planus can look identical. So even if you say there's widespread white lesions, that's what happens in lichen planus as well. So I don't begrudge the pathologist for diagnosing this as lichen planus, and I don't begrudge the clinician for treating it like that because the clinician did a biopsy and that's what we called it. But I just want you to be warned that these might look like lichen planus under the microscope. So if you're getting these big, thick keratotic lesions that are, look at this, sharply demarcated, lichen planus doesn't do that. Either send a picture or say you're worried about PVL. So here's what the tissue is doing on the roof of her mouth. Again, she actually no longer has these teeth. I sent her to be treated in North Carolina by my friend, Dr. Padilla, who treats a number of these cases. So here was a worrisome area for me. And then here's the other side of the arch. So not quite as worrisome, but it's getting there. And then you'll see this picture is out of focus, and that's because I've had to crop it quite a bit because I was actually taking a picture of something up here, and I was going through my photos when I noticed this, and I was like, oh my gosh, that needs to be biopsied immediately. So this looks like sort of a speckled erythroleukoplakia to me. So if I put the pictures side by side, we biopsied this area and this area initially. This was severe dysplasia. I was so happy it wasn't a squamous cell carcinoma. And this was just hyperkeratosis. So again, I sent her to my friend, Dr. Padilla in North Carolina, and he's managed her. She sees him every 3 months. And I believe these teeth are gone now, but she couldn't be happier with treatment. She does not have a cancer yet. So how do we manage leukoplakia? Well, first we have to come up with a diagnosis, because I can call this leukoplakia, but I didn't know it was diagnosis hyperkeratosis until I biopsied it. The biopsy is mandatory, and it does need to be taken from the most severe area of involvement, which can be a little bit difficult to determine, right? Like we talked about earlier, this is what sticks out to my mind, but this red area is what's actually going to be a more advanced dysplasia. Something else I wanted to bring up. So when I was going through school, I was always taught, let's wait 2 weeks to see if the lesion clears up. And then you bring them back. And then if the lesion's still there, then you either biopsy that day or you refer for biopsy. But the new thought, so this is evidence-based clinical practice guidelines put forth by the Center for Evidence-Based Dentistry, sponsored by the American Dental Association. So this was on the cover of the Journal of the American Dental Association in 2017. That's where I'm getting this information. So if you think your patient has a lesion that qualifies as a potentially malignant disorder, you should biopsy it that day or refer for biopsy that day. So don't wait 2 weeks. So if you have a patient like this, don't wait 2 weeks to see if it'll go away. Either biopsy it that day or refer it for biopsy that day. So to where do you refer? When I see patients and I see an oral potentially malignant lesion, I do my own biopsies. But if I don't feel comfortable performing the biopsy myself, I will send to an oral surgeon. If it's on the gingiva, I will send to a periodontist. You can, if you're close to a pathologist, you can refer to a pathologist, but you also want to ensure that number one, the pathologist does their own biopsies. And number two, there's some insurance considerations, like some oral surgeons take medical, some pathologists do, some don't. So we won't get into that, but just something to keep in mind. If you do your own biopsies, my lab, much like many other labs, will ship biopsy kits for free anywhere in the country. So the biopsy kits include the formalin, the paperwork, and all of the mailing. So you don't have to pay for shipping. We pay for 2-day shipping there and back, and we give you everything you need. And we ship everywhere in the country. And again, that's not unique to my lab. Most oral pathology labs do that. So I just said, if you think you have a potentially malignant disorder, biopsy or immediately refer for biopsy. So I do have some exceptions, and these are Ashley Clark exceptions. These have not been published in a peer-reviewed journal, but what I do in my practice, or what I advise young dentists to do who maybe don't have the experience that I have with oral potentially malignant disorders, is if you think it's geographic tongue, like this was here, but you're not sure, then go ahead and recall in 2 weeks. So this student had just graduated and then sent me this picture. And to this, doctor now, to my peer now, he said, well, this is a white lesion and a red lesion on the lateral tongue. So I should be concerned. It's the only lesion that they have. But he kept thinking, oh, it kind of looks like geographic tongue though. So of course, he reevaluated in 2 weeks and it was geographic tongue. So if you have a patient with a very small, painful ulcer of, 10 days duration on the tongue, common things happen commonly. It's probably an aphthous ulcer, but if you have any degree of suspicion, go ahead and bring them back in a couple weeks. Okay, so after the biopsy report comes back, now you need to know what to do with the diagnosis. And if you do your own biopsies, this might be new information actually. So hyperkeratosis or acanthosis, those are the totally benign lesions, but you still have to follow up every 6 months. And the literature says you should follow up every 6 months for 20 years, because this is still considered potentially malignant if it's a true leukoplakia. You can get hyperkeratosis on the ridge that's not a true leukoplakia, but a true leukoplakia, follow up every 6 months for at least 20 years, rebiopsy if the lesion changes. For mild dysplasia, the treatment depends. So it is well within the standard of care to just watch the lesion. Follow it every 6 months, take a picture. If it changes at all, then rebiopsy. That is okay. I personally recommend tissue destruction if possible, because surgical excision is the only thing I can do with my hands to decrease their risk of malignant transformation. Now, they can decrease their risk of getting a cancer by stopping smoking, but I can't do that for them. But if I cut out this dysplasia, I've lowered their risk by half. I have not eliminated it, but I've lowered it. If the lesion is small and the patient is someone who smokes, it is okay to reevaluate in 3 months after habit cessation. So they have to promise to quit. And occasionally those lesions will regress on their own. Now, when it comes to moderate dysplasia or worse, there is no let's watch and wait. You have to destroy the tissue. That's the standard of care. And by moderate dysplasia or worse, I mean moderate dysplasia, severe dysplasia, carcinoma in situ, and malignancies. So if you do your own biopsies and you get back a moderate dysplasia, just know that that tissue all needs to come out then. And I don't do my own when it comes to bigger lesions. I'll cut out tiny lesions of mild dysplasia, but I don't cut out moderate dysplasia or worse, I don't go back in and do those excisions. I send those to a surgeon. So again, like I said, 20-year follow-up every 6 months because recurrences are frequent and patients might get an additional, another area of leukoplakia or erythroplakia. Anywhere from 10 to 35% of leukoplakia recurs, with the exception of PVL, which has about 100% recurrence rate. And you do need to rebiopsy those recurrences to reestablish the diagnosis. And again, let's try to help the patient stop risky behaviors like smoking cigarettes and drinking alcohol. Because this is an oral pathology lecture, I've got to show you some pictures of squamous cell carcinoma. So this sort of portion is recognizing oral cancer. So I'm going to show you some rare presentations of oral squamous cell carcinoma. So the typical patient is an older white man who has been aware of an alteration in the mucosa. A lot of people will come to my office with these cancers for over a year and say, well, I had an ulcer, but it didn't hurt. So that might be why they're not going to seek care right away. And if I don't have a high degree of suspicion, it can delay treatment, it can delay diagnosis. And I see this happen over and over and over again on number one, the gingival carcinomas, and number two, the young women with tongue cancers. That's when I see the patient sort of slipping through the cracks. There's almost always a pre-malignant lesion first. So oral squamous cell carcinoma presents itself before, or shows itself before it turns into cancer. So there's usually or almost always a white patch or a red patch before squamous cell carcinoma develops. So these can look however they want. Basically, they can be mass forming, they can be invasive, they can be red or white or both. The exophytic lesions do have an irregular surface. It's usually ulcerated, can be white or red, and they're indurated. Indurated means it feels hard. Endophytic lesions, so those are lesions that sort of dive into the tissue. Those have a central ulceration where it's gone into the tissue. And then once it dives in the tissue, it spreads laterally. And when it does that, it pushes up a border. So these lesions will have rolled borders and they will be irregularly shaped. So the most common locations, you all know this, lateral ventral tongue, floor of mouth, but don't forget the gingiva. That's the fourth most common location. And these gingival cancers are painless and they mimic benign lesions. So they mimic periodontal disease. They're not really associated with tobacco. They're not associated with HPV, and they're more common in females. If cancer spreads, oral squamous cell carcinoma spreads, it does so via lymphatics. That doesn't happen too often with non-HPV driven cancers, maybe about 20% where we find the metastatic spread. But if that does happen, the nodes will be enlarged, firm, and painless. And if they're fixed, it's not a good sign. That means the tumor has broken outside of the capsule and sort of, chain linked itself to the surrounding anatomy. And the treatment plan is to recognize the lesion, refer to oral surgery. So I'm going to show you some quite obvious, to my eyes, quite obvious squamous cell carcinomas. So this one is an exophytic. You can appreciate that it's ulcerated and it might bleed easily. But here where the tumor is growing so quickly, it's lost its blood supply. That might be one reason it's ulcerated as well and necrotic. This was an exophytic lesion of the ventral tongue in a person who had been smoking for a very long time. The surgeon did not have a high degree of suspicion and cut it off as though it was a fibroma, which made it sort of hard to tell where the margins were, but luckily we had this photograph, but this was a squamous cell carcinoma. Here's another one. You can appreciate what I was talking about, this central ulceration, and it's not like a nice round ulcer. It's irregularly shaped, and as the cancer's diving in and moving laterally, it's pushing up the tissue around. So that's why you've got this rolled border. And if you were to palpate this, like put one finger here and squeeze, it would feel like you were squeezing a rock. So these are usually rock hard, unlike, recurrent aphthous ulcers that really don't have that induration to them. Here's another example of an endophytic lesion. But over here it's exophytic, and this is floor of the mouth area. And don't trust anything on the floor of the mouth. These cancers they like to live there, and they can be small. Another example of an endophytic squamous cell carcinoma. This patient was a physician, a family physician, who presented with he had stage 3 squamous cell carcinoma by the time he came to me. And that's because physicians don't really get any training, if at all, on what oral cancer looks like. So it's really our job as the dentist to catch these in their early stages and get them cut out. To me, this is sufficiently ugly that it looks like squamous cell carcinoma, but I can see where some people might think it's mimicking some sort of infectious or some sort of process like that, inflammatory process, but that's definitely a squame. This patient, her chief complaint was her denture was no longer fitting. And so she went to have her denture adjusted, and her denture was adjusted, and then it fit better, but she still had this big cancer sitting there that nobody addressed. So unfortunately for her, this was very advanced by the time she got it diagnosed. And this is another example of squamous cell carcinoma. You're not going to miss this one. I just want to show you how big these gingival cancers can get. So it starts up here, but it goes all the way back here. I don't know if you can appreciate that from your home screen. So just a massive squamous cell carcinoma. And the radiograph I have is not of good quality, but I think it's enough for you to appreciate what it's doing to the bone. So it's just eating out the bone. And then, of course, this is clearly a malignancy, but this had to be biopsied a few times before we got our diagnosis, because the top of this is just all straight up necrotic tissue. So we weren't able to call it cancer until they got a nice slice where we could see past the necrosis. So now I want to show you some unusual presentations of squamous cell carcinoma, just so you can kind of get your eyeballs on them. And if you see something like this in your practice, so first of all, I'm going to give you my email address at the end. I will take pictures from every single one of you and let you know what I think. So if you want to use me as a resource, you feel free. But here is a big ulcer. To me, this looks like cancer, but I can see where someone might be fooled because it's on the buccal mucosa. And buccal mucosa is sort of unusual place for oral cancer. Here is a small ulcer. You can appreciate the rolled borders, but this was a squamous cell carcinoma. So just a nice reminder that if they're wearing a removable prosthesis, to go ahead and have them remove it so you can complete your oral cancer screening. This is a cancer that, of course, in hindsight, of course, this is a cancer. However, I can see this being easily misdiagnosed as a recurrent herpetic infection or a traumatic ulcer. Now, this had been there for 8 months, so we knew to biopsy it, but this is mimicking a herpetic lesion or a traumatic ulcer. Here is a 17-year-old female. This patient presented with what I would consider to be a interdental papillary mass, or a interdental proliferative mass, a bump on the gum, if you will. But this was a well-differentiated squamous cell carcinoma in a 17-year-old female. And you can see these gingival squamous cell carcinomas. My maiden name is Newman, so I've been sort of obsessed with them for a long time. I published this about a decade ago. So this was a well-differentiated squamous cell carcinoma in a 17-year-old. This is a patient where there's no reason she should have cancer. There's no history of tobacco or alcohol. So the dentist just went ahead and removed this lesion, but did not submit the tissue for histopathologic evaluation because it looks vascular. And even to my eyes, it looks vascular. And I'm used to seeing cancer all day, every day. But anytime you have a red lesion on the gingiva like this, you ought to biopsy it just in case. And this did turn out to be a squamous cell carcinoma. They biopsied it when it returned. Another example of a squamous cell carcinoma maybe looking like an aphthous ulcer here. So some main differences: aphthous ulcers will be painful, and squamous cell carcinoma in the early stages painless. I can appreciate sort of an erythroleukoplakia going on here. There's also an ulcer here and here. If you were to palpate this, the ulcer would be quite tough or indurated. But if, I'm sorry, this is a cancer. Because this is a cancer, it'll be indurated. But if this were an aphthous ulcer, it would be really soft to the touch. And then, of course, any ulcer sticking around for longer than 2 to 6 weeks must be biopsied to rule out squamous cell carcinoma. And unfortunately, that's what this was. Another example of misdiagnosis. Now, to me, this looks like a traumatic ulcer 10 times out of 10, 7 days a week. But this was misdiagnosed as a denture-related traumatic ulcer. So it went a while before it was biopsied. So it just goes to show that, even with Epulis and Epulis fissuratum, you're meant to biopsy the tissue and turn it in. And luckily, these folks did after a while. Very scary appearing lesion. This was a squamous cell carcinoma. This is erythroplakia. So just be thorough in your oral cancer screening so you don't miss the stuff like this. And then anything on the floor of the mouth that I don't know why it's there, I don't mess with it. So this was a squamous cell carcinoma, even though this is so tiny, but you can sort of appreciate some fullness here. But just biopsy it, and 1,000 times out of 1,000, this will be a fibroma. But every once in a while, you just never know. So I always biopsy things if I don't know why they're there, especially in this area. So how do we decrease risk? So we do it via smoking cessation and vaccination, and that rhymes. And if you could see my face, I would have done like a little dance, but I just feel too silly to do it now. But so smoking cessation and vaccination. The role that we play in tobacco cessation is, number one, we want to screen patients for use, document their use, and then advise to quit. So here's the 5 A's. And I know this was like probably a test question in dental school that you had to answer, but I actually do use the 5 A's in my practice. So I ask if they use tobacco. I admit I don't always advise to quit, right? Because a lot of these folks know they're not supposed to be smoking. So I'll say, do you smoke? And they'll say yes. And depending on the personality of the patient, I might say, well, I'm going to tell you, right? I'm going to tell you to stop. You know that. Or I might just go straight to assessing their willingness to quit. Like, well, are you ready to quit at this time? And if they say yes, I say, great, I will help you. I assist them. And if they say no, I say, okay. And then I drop it. And then at the next appointment, I ask about tobacco use, assess their willingness to quit. I rinse and repeat. So for assisting in quitting, I'm going to show you some things that we can do. But the arranged follow-up. So what I usually do with my patients is I say, okay, well, what's your stop smoking date? And then I'll call them that day and then a week later, if they want me to. So that's how I can, they were really stretching for that 5th A here for arranged follow-up, but that's how I follow up with my patients to make sure I'm supporting them as much as I can without pestering them or making them feel bad about themselves for smoking. So there are pharmacological cessation tools. Varenicline, this is Chantix. That works in 25%. If you combine it with a nicotine replacement therapy, that is, according to our studies, the best way to quit smoking. And even then, less than 1/3 can quit. So it's really hard. So you have to encourage your patients not to be too rough on themselves. So nicotine replacement therapy alone, you can read how often these work. We can, as dentists, prescribe Chantix. And if you would like for me to give you the prescription and how to write it, I certainly can. I choose not to write this medication just because it's associated with so many side effects. And I don't see my patients as regularly as the general dentist or the periodontist or the, et cetera, sees their patients. So I don't know them as well to know, if they have a mental disorder or if they're going to call me if they're feeling depressed, et cetera. So I let the physician prescribe this, but dentists are well within their scope of practice to prescribe it. So if you'd like the prescription, just send me an email and I'll get it to you. So the other thing, even though we didn't talk about high-risk HPV, we can recommend to our patients that they be vaccinated against high-risk HPV. The current one, so Gardasil isn't available anymore. It was the oldest or the first one on the market. The first one was quadrivalent, meaning it protected against 4 strains, and it was 6, 11, 16, and 18. And it was available for women in 2006 and men in 2009. Now we have Gardasil 9 for both. So they kept the original 4 strains and added 5 new high-risk strains it protects against. This is the recommended one. And you want to get vaccinated before the patient is sexually active. So the recommended age is to start between ages 11 and 12. That's what the Advisory Committee on Immunization Practices says. And the reason I point out that it was available for women before men is because when we think of HPV-associated cancers, we probably think of cervical cancer. However, since around 2012, and certainly last year, more men are diagnosed with HPV-driven oropharyngeal cancer than women are diagnosed with HPV-driven cervical cancer. It's actually more important for the men to be vaccinated. They're the ones that are getting more of the cancers. So I've had 2 main sort of hesitations for why patients don't want to get the vaccine. Number one is because they are afraid it will encourage sexual promiscuity in their children. And that's been studied, and there is no correlation between vaccination and number of sexual partners, age of sexual debut, et cetera. So it's just not, it might be a worry, but it's not something that is ever been proven. There's no correlation between vaccination and any sexual behaviors. The most recent one that I've heard is that, I got the HPV vaccine and then I got HPV from it. But that's impossible. The vaccine does not have genetic material. It's created from virus-like particles. So in conclusion, 1 in 200 of your patients, up to 1 in 200, have oral dysplasia. So we want to screen every patient every time. Dysplasia does carry a significant risk for malignant transformation, 10 to 30% in normal cases. And the risk does increase for severe dysplasia or worse. What we can do to decrease the risk of malignant transformation is surgically excise the leukoplakia, but keep in mind that does not eliminate their risk of malignant transformation. So we want to follow up patients with leukoplakia every 6 months for 20 years at least. We don't really know about HPV, that the leukoplakia is driven by HPV. Those are called HPV-associated oral intraepithelial neoplasia. It's easier for me to call them HPV leukoplakias. But at any rate, those have about a 20% malignant transformation rate. And I saved about 10 minutes, I hope. Yes, 12 minutes to answer any questions you have. I will answer the ones about this topic first, but if you have any other oral pathology questions, I'm happy to answer them. So I've got a couple of questions right now. What about the younger generations using a vape? So great question. More teenagers, about twice as many teenagers have used electronic cigarettes when compared to traditional cigarettes. So this may be a problem in the future. And 75% of people who are using electronic cigarettes are using a pod system known as Juul. These are systems that they look like flash drives and you can charge them in a computer. So I think most parents have caught on by now that those flash drives are actually electronic cigarettes. So the contents of a Juul is, it's propylene glycol, and that's the stuff that causes fog at concerts. So that's in there. nicotine, and flavoring agents. So there's only 3 ingredients, and you're not lighting it on fire. But when you're smoking, cigarettes only have 10 to 12 ingredients, but you light it on fire, which releases anywhere from 2,000 to 4,000 potentially cancerous chemicals. So while we don't know if vaping is better, it almost certainly is better, but it also hasn't been around long enough for us to know if it leads to any potentially malignant disorders. So if you remember from one of my first slides, the young women who are getting tongue cancers, even if they do smoke, it's not considered enough of a time. And vaping has only been around for so long. So we just don't know if it's going to cause any bad effects yet. The popcorn lung things that you may have heard about, those are not the Juuls that kids are using. Those are to smoke liquid THC. What are the treatment options for PVL is one of my other questions. And the treatment options are laser off, cut off. Those are the only treatment options we have. It's really unfortunate. Can sexually active or older people not get vaccinated? So great question. The vaccine, the Gardasil 9 vaccine, was only available to women ages 9 to 26 and men ages 9 to 21 up until August of 2018. Since then, both men and women, or I guess I should say boys and girls and men and women, can get the vaccine up to age 45. So the reason they set those ages is because HPV is so ubiquitous that nearly 100% of people who have ever had any sexual encounter have most certainly had HPV and then cleared it. So on a population, but once you've had it, you can't be vaccinated against it. So on a population level where they make these health decisions, it's not cost effective to vaccinate a bunch of people who have likely been exposed to a bunch of strains already. So that's how they make their decision on recommendations. But how you make your decision should be based on what you want. So I'm 37, I'm married. They would recommend I not get this vaccine, but it's totally fine for me to get it if I want to, because I'm not going to make my health decision based on money as a whole, basically. Oral cancer risks with marijuana use. Yes, so marijuana use actually increases your risk of HPV-driven oropharyngeal carcinoma because the cannabinoids bind to the tonsillar tissue. And long story short, not to bore you with the mechanism, it makes it harder for the body to clear the virus. So people who smoke marijuana tend to hang on to those high risk strains in the oral cavity more often. So there is an increased risk for oropharyngeal squamous cell carcinoma in patients who use marijuana. Someone asked me about pemphigoid. I do encourage you to email me at this email address, and I'm happy to give you advice on diagnosis and treatment. Someone asked, is PVL symptomatic? And the answer is no. It's not symptomatic. The patient is totally asymptomatic. They might feel like a roughness with their tongue, but that's it. Next is how many doses of Gardasil 9 are necessary for vaccination? And the answer is that depends. So if you start the series before age 15, it is a 2-dose series. If you start it after age 15, it is a 3-dose series, given at 0, 2, and 6 months. Dr. Dan, hello, good to see you. I have a young lady who bites her tongue left and this is what I know Dr. Dan, sorry. So he's asking me about a patient who bites her tongue left and right and the tissues look traumatized. Should we biopsy, try to cease the trauma and watch the lesion? Well, it depends because there are things that can look like tongue biting, white striation, like oral hairy leukoplakia. So I'm not exactly sure if it's traumatized over a lesion, if you know what I mean. So if you want, you can take a photo of that and just text me if you still have my cell phone number or send me an email. But if not, you could try to make a mouth guard and see if, you know, in a couple of weeks, if the lesions sort of go away. If not, you can always biopsy it. Do we know the prevalence of parotid cancer? I have a patient waiting to get a a biopsy of her parotid gland? The answer is about 2/3 of tumors found in the parotid gland are benign, meaning 1/3 are malignant of those salivary gland neoplasms of the parotid. So pretty good chance it's going to be benign. Do I see any benefits with oral illumination devices such as Velscope or Oral ID? So for me, I don't use those products. However, I think they're very helpful if you're trying to determine where to biopsy, not necessarily if. So the way most people use those screening devices is not the way they were intended to be used at first. So when they first came out on the market, it was, hey, you've seen this white lesion. Now let's shine this light on it to see if it has dysplasia. But that's not how hardly anybody uses these devices, right? So how we use them is we do our conventional exam with the overhead light, and then we shine the oral illumination or tissue autofluorescence device. And that is a totally appropriate way to use those devices. And I think it's quite helpful in determining the worst area. If you're going to do your own biopsy, like where should I biopsy it? How reliable, though, is Velscope or Oral ID? Well, they're pretty sensitive. So if you have a cancer or dysplasia, they're probably going to pick it up. They have over a 90% sensitivity, but they're not specific. So that's why you shouldn't use it as a decision-making tool. Like if you see a white lesion, you should biopsy it. You shouldn't shine a light on it to determine whether you should biopsy it, because it's always going to say biopsy anyway. So I hope that answers your questions about these oral diagnostic adjuncts. Let's see. Do you take the person's word that they haven't had HPV? So most people who have had HPV have no idea they've had it. So I just assume that everyone's going to say they haven't had it. Yes, I gave a handout with everything I could give to you. So certain pictures I'm not allowed to give because they've been published, but someone asked if you could have a handout, and of course you can. Email me if you are having trouble. So if a patient refuses to go to an oral surgeon, so number one, how do you get them there? I would just say, I can't promise you this isn't cancer, and I would send them a certified letter. And you have to do whatever is necessary. You're not necessarily responsible for biopsying it yourself as a GP if that's outside of your normal practice, but you are responsible for letting patients know that you think they need a biopsy. And now they have autonomy, but you might have them sign a piece of paper saying, hey, when this turns out to be cancer, you're not going to sue me, something like that. Are there any pharmaceutical treatments for leukoplakia? And the answer is not that I'm aware. Are brush biopsy kits adequate? So the short answer is sometimes. That article that the Journal of American Dental Association, that evidence-based clinical practice guidelines, that October 2017 article. So they suggest always offer scalpel biopsy first. If the patient refuses, then you can use a brush biopsy, but you should not use a brush biopsy before scalpel biopsy. All a brush biopsy can do is tell you yes or no. Yes, there's abnormal tissue. No, there's not. It can't tell you the diagnosis. It's because it could be hyperkeratosis or cancer. So you need a scalpel biopsy anyway. The other thing is, if you're doing a true brush biopsy and not exfoliative cytology, so if you're using a true kit and you're sending it back to a company to be read by a computer, that actually has a pretty good specificity and sensitivity. So I'd be okay with it if your patient absolutely refuses scalpel biopsy. You can use that as sort of another tool to convince them to get a biopsy. So someone's asking for my email address. So it's here on the screen. It's ashley.clark.dds@uky.edu. Feel free to email me if you have pictures or questions. I might be late in getting you a response, but I will do my best to answer as quickly as I can. And Trung, I don't want to go over, and I notice it's 7:59, and so I've been talking 1,000 miles an hour trying to get to all these questions. But if you want to take over, you certainly can. If I didn't get to your question, please feel free to email me.